Good afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Mark Pletcher of the University of California, San Francisco, as he presents on the PCORnet Blood Pressure Control Laboratory. Dr. Mark Pletcher is a professor and interim chair of the UCSF Department of Epidemiology and Biostatistics and director of the UCSF Clinical and Translational Science Program's Informatics and Research Innovation Program, the goal of which is to harness emerging technologies for the purposes of research innovation and efficiency. He conducts research designed to inform clinical decision-making and prevention policy, particularly for the prevention of cardiovascular disease. With colleagues at UCSF, Dr. Pletcher has pioneered the use of digital research platforms for engagement of research participants, launched a national blood pressure control laboratory, and supports a learning health system demonstration projects program that conducts embedded randomized controlled trials. He also teaches research methods and mentors students, fellows, and junior faculty members. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions to the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Mark Pletcher for the PCORnet Blood Pressure Control Laboratory. Dr. Pletcher, the floor is yours.
Thank you very much. Okay, I'll share my screen here and get into presentation mode. Okay, William, you can see my screen okay?
Looks great.
All right, so I'm looking forward to talking through the blood pressure control lab and how we've worked with OCHIN over the years to do some cool stuff, I think. I'm going to just give a sort of conceptual overview of the BP Control Lab. And then we have these three projects that we did through the lab and were funded by PCORI, BP Track, BP Map, and BP Home. So I'm going to talk through each one of those relatively briefly because there's a lot to cover. And then I'd be happy to, well, first talk to you about what we are thinking about will come next, and then happy to answer questions. Before I launch in, I just wanted to acknowledge a bunch of people here. I won't spend too much time at this, but I just wanted to put all of our OCHIN colleagues at the top here. Jonathan Todd, I think, is no longer at OCHIN, but he really was our primary partner, investigator for the BP Control Lab work. And April Lee and Nate Warren, I think, maybe on the call, and really appreciated both of their great work with us over the years, and have worked with a bunch of other people as well in developing some other ideas for future proposals, which we're still sort of in progress for. And I just want to note that we love partnering with OCHIN and consider OCHIN really a unique network and partner. I also want to thank OCHIN clinicians and patients, and I don't think we're allowed to name them, but maybe some of them, those people are here today. I just really want to thank you all as well for the role you all have played in our projects. And then I won't name others further, but we have others you might know from the work, Valley and Madeline in particular. Madeline, I think, is on the call today. Okay, so the BP Control Lab really focuses on, of course, blood pressure control. And uncontrolled blood pressure, I think, very simply is the, or at least among the leading preventable causes of death in the US, depending on how you calculate things, but it's really one of the major opportunities that we have for reducing cardiovascular disease mortality and overall mortality in the US, as well as reducing the inequities in health that we clearly see in the US. There are very large ongoing disparities in blood pressure control by race, ethnicity in particular, that I think are potentially amenable to reduction and thereby reducing the overall inequities in health outcomes in the US. So that's really the problem here that we're trying to solve. And the opportunity here is that we do, of course, have effective medications for blood pressure control. And as the clinicians in the audience know, there are very, very many options for medications. And it's very rare that we can't get a given patient under control if the patient and the doctor have enough time and shared sort of commitment to that goal and an opportunity to actually use those medications, we can get patients under control. That's not really the issue. More really is about how we do that effectively and pragmatically in the context of clinical care, which is hard because it just takes time and ongoing attention and efforts from both clinicians and patients, the way we currently do things. There are a bunch of new technologies coming out, which I find very exciting, potentially for measurement of blood pressure and otherwise to give us more options for how we try to control blood pressure pragmatically in the context of clinical care here, that I think are worth ongoing study and are exciting new opportunities. And the other opportunity here is that we have really in the last decade developed a major system for doing research, which is using electronic health record data. And EHR data is in particular quite useful, somewhat uniquely for blood pressure control research, because unlike most other measurements that we make in clinical care, blood pressure actually is recorded as structured fields, numbers that are written into the database at almost every visit to an office. So those measurements are things that we can get and use for research, and allows us to do things with blood pressure control research that we can't do with other conditions. So that's the opportunity. The vision here for the blood pressure control laboratory is to attempt to help us do better in terms of controlling blood pressure at scale in the US. That's really our vision and our hope. And we do that. We think the blood pressure control lab can help us do that by using, first of all, the EHR data that we have for surveillance, knowing what's happening in the US, both in terms of blood pressure control outcomes as well as processes, which I'll talk about in a minute. And then by testing interventions in the real world to see what works. So I want to focus in for a moment on PCORnet in particular, because that's part of the name here and the context. What is PCORnet and why is it useful? Well, electronic health record systems in the US are complicated, and they're not the same across different organizations. We have every organization tends to have its own electronic health record system, even if it's the same brand like Epic or Cerner. They customize it locally, which produces data which is different in every institution, data with different tables and variable names and meanings of various sorts with different coding schemes, which makes it really hard to analyze across sites for multiple studies. And that's what PCORnet helps with, really primarily, is by putting in the investment to standardize that data across different health systems into what's called the PCORnet common data model. And that harmonization allows us to analyze data across institutions in a way with a single query that works the same way across different institutions. And it's a much more efficient way to do research than working with all those heterogeneous data warehouses. Okay. PCORnet includes also a coordinating center, which really helps do the work of querying health systems across all these sites that participate in PCORnet. Along with that coordinating center and common data model, there are mechanisms established to make contracting easier, and also networks of collaborators, which frankly is a lot of the value also of PCORnet, is that we have people at each of these institutions that we know, and we know how to reach out and set up arrangements and collaborations. We trust each other, et cetera. And that's an important part of the network as well. Okay, how does OCHIN fit into this? Well, OCHIN is a PCORnet partner, and it's quite a unique partner as well, in that unlike any of the other PCORnet institutions, OCHIN focuses on primary care ambulatory care and safety net patients. I hope I'm not making any misstatements about OCHIN, but this is my understanding. It's a very large network with a very large number of health systems and clinics that are engaged and using OCHIN Epic, which produces very high quality data in the PCORnet Common Data Model. And also there are lots of very high quality people and researchers that have a lot of experience in using that data, and they're just a great network to collaborate with, in particular for blood pressure control, which is an outpatient type endeavor, as we all know. OCHIN already has a focus on quality of care, and even if we could only develop an intervention that worked only at OCHIN sites, we do already have a large potential impact and route for disseminating that to across OCHIN to help improve quality of care for blood pressure control. So we love working with OCHIN. So the blood pressure control lab, what we do with PCORnet and this institution is to use electronic health record data for tracking blood pressure control over time and for surveillance. We use the lab for finding collaborators, for finding patients to engage, which I'll tell you more about in a second, and for tracking the outcomes of those patients and evaluating the success of our interventions. So this is just a design paper. You can look if you're interested in the BP Control Lab and the theory behind it and the platform and opportunities. I might point you to this paper to learn more. But now I think I will switch to talking through the specific projects that we've used the BP Control Lab for. So we have these 3 projects. BP Track is our surveillance project. BP Map is a cluster randomized trial. That is, we randomize clinics to 2 versions of a quality improvement intervention and saw what happened. BP Home is an individual patient level randomized controlled trial where we gave patients 2 different versions of home blood pressure monitoring technology to use. Okay, BP Track, first of all. So this is our surveillance project. We really wanted to understand how much variation there is in blood pressure control across different health systems and within health systems across the different clinics and clinical units that we can analyze using our queries. We can look clearly over time and see how things are changing, looking for improvements, hopefully, in blood pressure control as the nation really focuses in on this problem, as it has done in the last decade. We can look at some of the processes that drive blood pressure control, where the primary gaps may be, and where there might be disparities in outcomes and processes where there really are potential opportunities for interventions. So this is an observational study, but one that is designed to help us find and exploit opportunities for improvement. We start kind of with this process model. This is the blood pressure control model that Valley Fontiel and I developed a number of years ago. It's pretty simple, but it kind of outlines the sort of basic processes that have to occur when a patient comes in with hypertension to one of our clinics as a primary care patient. They have to have office visits generally to understand what their blood pressure is, at least the office blood pressure measurements. So that measurement step is one important part of blood pressure control. And then if blood pressure is uncontrolled, either they need to get some sort of intensification in their medical treatment or not. And even if they get a medication intensification, there's variability in the effect of that medication, and may depend on what kind of medications we use and how effective the intensification is in terms of, for example, a dose increase versus adding a new medication class, which is generally more effective. And then even with intensification of a treatment that's been prescribed, in order to get an effect, the patient needs to be adherent to that medication and actually take it. So each one of those steps in the process has to actually occur, and often repeatedly, in order to get blood pressure under control. And that complex process is essentially the main barrier to us really attaining better blood pressure control for our patients. So with that in mind, we designed a set of metrics that we analyze in BP Track. These first three are really outcome metrics. So this first one is the percent of patients who are currently under control, if we define control as the sort of traditional older threshold of 140/90. It's the percent of people with needing a diagnosis definition of having hypertension who are under control. And then metric 2 is that same metric except to the lower, newer threshold of 130/80. This improvement in blood pressure is a metric designed to show how patients who start uncontrolled may get closer, substantially closer, by improving their blood pressure a certain amount, I think 10 milligrams per mercury, or achieving control. So that's a different kind of outcome metric. And these other ones are process metrics. So these first two are designed to address the issue of measurement in clinic. Do we do measurement correctly? Do we repeat the measurement when it's high, which is what guidelines tell us to do? And then when we have an uncontrolled measurement or a patient with uncontrolled blood pressure in clinic, do we intensify treatment? And the way we define this medication intensification metric is really by prescription of a new class of medications. That has some limitations to it because sometimes we just increase the dose as clinicians. But that increase in class is considered to be really the recommended best way to go, and it's a much more reliable measurement within PCORnet. And then when patients are uncontrolled, we really should see them back. So we have this metric of repeating their visit within 4 weeks after uncontrolled blood pressure. When we do a medication intensification, we also measure the average systolic blood pressure reduction, which I'll show you in a minute. And then we have these two metrics about sort of prescribing quality. That is, this first one is looking at just African-American patients with hypertension who are on at least one medication and making sure they're on either a calcium channel blocker or a thiazide diuretic. And this next one is use of a fixed dose combination product among patients who are taking at least two classes of drugs, which is, again, also the recommendation. Okay, I'll just note that these hit a number of really all of the main basic steps in our process model. And then these first three are the outcomes that we get after we measure blood pressure. And we have a lot more description of the methods here in this paper that we published, which I'll just summarize briefly for you here. This is from wave 4 of BP Track. We have 25 health systems included. OCHIN is just one of those, so a bunch of other health systems are involved in BP Track. The total number of patients meeting criteria for hypertension is very large, 1.7 million patients analyzed in wave 4, and then includes data not going back too far because we don't have the common data model consistently mapped and supported in prior years, but this period from 2017 to 2019 is still interesting and provides some information about the time trend. And here is the time trend. So this is from 2017 to the end of 2019. And you can see the main metric here across all patients is in the dark line. It's at about 60%, 62% actually at the end here at the most recent measurement period. And you can see across these different race ethnic groupings that there is a disparity in Black patients in particular who have about 5% lower blood pressure control rates than patients of other races and ethnicities. So that's the disparity that we know is present and continues to persist in the US. You might just note here, there's a little bit of actual seasonal variability, which is kind of interesting in blood pressure control. It has been described a bit in the past, but you can see it in our data as well. Okay, this is a little busier, but I'll just talk through these main results looking at our process metrics. So this is the 62% overall blood pressure control to the 130 over 80 threshold. It's a much lower, so 30% are meeting that threshold, and about 30% in any given year appear to have substantial improvement in blood pressure control. Measurements are repeated when they're high, and that's documented in the chart only about a quarter of the time. So that's an opportunity. This is a real opportunity, medication intensification, where when we have a patient with uncontrolled blood pressure, only 12% of the time are they getting a prescription for a new class of blood pressure medications. And then only about a third of the time are they seen back within 4 weeks. When a new class of medication is prescribed, a very large increase or sort of reduction in systolic blood pressure on average occurs. So that's really good news, actually. Thiazides and calcium channel blockers are often used in Black patients. However, fixed dose combination products are not often used in patients on 2 or more medications, and that is another opportunity for process improvement. I'll just note this one, as well as these, really appear to us to be some of the major opportunities here. And this one in particular, where these rates are so low, and when it happens, the reductions are so high that this shows, of course, that medications are effective. We just need to use them more often when patients come in with uncontrolled blood pressure. And this is an opportunity as well. I think it's not, although this is kind of a soft recommendation out there, it's I think an opportunity for us to do better, make things easier for our patients, and get people slimmed down on the number of pills they need to take and such. Okay, is this BP track system useful for guiding quality improvement? This is another question that we asked ourselves, and we did actually return back the blood pressure control statistics for specific institutions, at least those that gave us information on specific clinics. This is data from one of my colleagues, Rhonda Cooper-Dehoff at University of Florida, that looked more deeply into 3 of her clinics here, just to show where they are on the plot. This one is pretty interesting because generally they're doing pretty well, and this one in particular has made big improvements over time. And you can see that against the background of the general sort of distribution of blood pressure control in the US, at least in our BP control lab sample. This is a place where these clinics are maybe doing less well, actually, these same clinics than the others, and that I think Rhonda found interesting, and her colleagues at University of Florida also found interesting, as well as this one, which shows this particular clinic and this metric. This clinic was an outlier, where you would expect, just by chance, that if you had an electronic monitor, you would see only 10% of measurements having a terminal digit of 0, or 20% maybe if you had people manually reporting what they found, because there's generally a recommendation to round to the nearest even number. But really, you shouldn't have numbers up here, and that's indicative of too much rounding. This is a measurement process issue that you can see at this clinic as an issue. Okay, so that's an example of how we might use those metrics locally to improve quality. And finally, I just wanted to show BP track. We have some more recent results from Wave 6 that includes 2020 and shows us what happened, at least in the first year of the pandemic, which is pretty dramatic here. And in fact, you can see this trend in blood pressure control that we saw before, and then it drops off a cliff, essentially, with the pandemic. And it has not started recovering, at least at the end of 2020. And one of the reasons for that is that the visits and repeat visits for patients with uncontrolled blood pressure really dropped off a cliff. recovered to some degree when people started seeing patients again in the middle of 2020, but really in person, that is, and but had not recovered by the time we ended our wave 6 queries. Okay, conclusions for BP track. A lot of variability here, a lot of room for improvement, persistent disparities. There are specific gaps that I think represent opportunities for us to improve quality, and clinic level results that I think can be illuminating, as well as disruptions from the pandemic, which really deserves follow-up, which we are going to do. Okay, next project is BP MAP. So I'm going to go through these next to a little faster here. These are both randomized trials. BP MAP is a cluster randomized trial of this quality improvement program that the American Medical Association has developed. It's focused on measuring accurately, acting rapidly, partnering with patients and families, meaning for home measurements and such, and communication. That spells MAP, if that's not obvious. And there's a clinic level program that goes with this that the AMA has developed over time. They have evidence of benefit for this when they really, work closely with the clinic to implement it clearly and put the processes in place to improve all these 3 sort of dimensions of care. But the question we wanted to ask was, does it work when we scale this up and implement the program at multiple clinics at the same time? And can we compare 2 different versions here? One is a self-guided format where we really just provide a digital guide to using the intervention materials, versus a more fully supported version where we have AMA staff actively meeting with practice facilitators and helping them implement the intervention. Obviously, it would be nice if the self-guided version worked just as well, would allow us to scale up more effectively. So this is where we engaged OCHIN clinics as well as others at a different network. We engaged with leadership, got buy-in from clinics to give this a try, identified site champions and physician champions at each clinic, and a practice change facilitator that was across sort of the network of clinics. We then randomized clinics to either the full support or the self-guided version of the intervention. We had a 6-month program starting with a kickoff meeting for all the sites, access to the training materials via this digital guide. We had monthly reports of our BP track metrics and a dashboard that clinics could use that allowed them to drill down into particular patients and see who was out of control, et cetera. And for clinics in the full support arm, they also got access to AMA experts who are to help them through the implementation of the program. This is just diagrammatically speaking. We had 24 clinics total, randomized 12 and 12 to self-guided and full support. We also had the rest of BP track. This is a non-randomized control group that did not get any intervention, but we also tracked over time to see how maybe there was changes in blood pressure control overall through the country that we wanted to make sure to control for. And these are the basic results. You can see some small improvements in both the self-guided and the full support clinics. This is the outcome of blood pressure control to 140/90. This black line is the usual care group, which went down just slightly. And when comparing here, we actually don't find a difference. This is the comparing self-guided versus the full support version of the interventions. We find a slightly larger effect in the full support version, but it's not statistically different from the self-guided version. And unfortunately, it's not quite statistically significant compared to the usual care group either, although there is a larger difference there, if that makes sense. And likewise, just a smaller difference here in the self-guided versus usual care comparison. We looked at specific metrics as well as the outcome and really found a large difference just in one of the metrics, which was the confirmatory repeated blood pressure measurement, which increased a lot in our full support clinics and also in the self-guided clinics. We did not find big changes in the other metrics. In particular, medication intensification did not change at all. And I'll just note that this measurement module of the intervention was the first thing that clinics engaged with, and perhaps the easiest thing to do. And maybe that's why we saw a big change in that one. So, in retrospect, we think the implementation plan and the way we scaled it up with the AMA was flawed, that we didn't really provide enough resources and attention for each clinic to make the major workflow modifications that are required for the MAP-BP program. And really just want to acknowledge what it's hard work to do quality improvement and really to make changes in workflow. I'd be curious if people in the group have comments about that from specific experience. I'd love to take some questions on that. Okay, our last project was BP Home. This is our individual patient level randomized trial. The question here is how to do self-measurement of blood pressure. Self-measurement at home is recommended by guidelines. There's data showing that it by itself, it's kind of not that effective unless you provide other support and engagement and help for patients to programmatically to help them use the measurements effectively, transfer the measurements to the doctor, get and do the sort of complete the whole cycle of all the processes that need to happen. All that costs a fair amount of money though. So we thought, and our patients actually helped us ask this question and formulate it, is whether or not a connected smartphone with a smartphone app was enough to actually make a difference in blood pressure control monitoring at home. That is, does adding a smartphone connected to your home monitor, which allows patients to automatically track what their blood pressure measurements have been, to visualize those measurements, to remind people to do the measurements and to talk to their clinicians about them, helps them interpret some of the measurements, et cetera. Is that enough to make a difference in terms of blood pressure control outcomes compared with just using a standard home blood pressure monitor that doesn't connect with a smartphone app? The basic design of the study was to find 2,000 patients who were uncontrolled and interested and had a smartphone, randomize them to getting a standard monitor or a smartphone linked home monitor. We delivered these devices to patients and we didn't give them anything else really, besides a little bit of technical assistance in using the devices. And then we saw what happened to them in terms of their blood pressure control. In particular, we used the office-based systolic blood pressure measurements from baseline to change at 6 months. We also looked at a net promoter score to see how well patients liked using the device. I'll just note, process-wise, this is a kind of an innovative approach to doing a randomized trial here, where we used the electronic health record to find patients with uncontrolled blood pressure and invited them to join the study. OCHIN clinics, I think, primarily did this by mail. So they sent postcards and then letters to patients, giving them information about how to sign up for the study on our research platform, which was delivered through a website, essentially. We then saw people enroll in the study and then mailed them devices after they got randomized. We had them fill out some surveys at baseline before randomization as well as during follow-up, and then looked at the electronic health record data, which they gave us consent and authorization to use, and looked at systolic blood pressure in clinics at 6 months. I'll just note, a lot of this is facilitated by the electronic health record system. That's part of the innovation of the study here. I'll also note we used this research platform that we developed at UCSF for digital enrollment of the patients, as well as for connecting the devices in the smartphone connected arm. We actually connect those to our research platform and get the home measurements from those patients for analysis. And I'll show you a little of that information as well. This is one of the real successes of the study, is that OCHIN and our other collaborators really helped us do recruitment into this study ahead of schedule. And that is almost unheard of in randomized trials, that you are able to find and enroll this many patients on a schedule and not get behind. This just tends to be very hard to do, but we were able to do that with our methods, and including enrollment of patients who are not just high educated white patients, but also Black patients and patients who are Latino or Latinx. We were very successful also in making sure that the patients we enrolled, we also had linked electronic health record data. We lost a couple of people where we couldn't figure out how to link, but very, very few. So that was also a success. We just recently published these results, and let me show you the basics here. This is the really the bottom line outcome here is that we did see a substantial reduction in systolic blood pressure, which was high around the time of enrollment, and then went down to about 140 during follow-up. These are measurements by month over time. But you can see that the two groups, red and blue here, really had about the same effect. So that's the bottom line of the story. An effect, but no difference in the effect by group. So we saw about this 10 millimeter per mercury systolic blood pressure drop in both groups. We actually found a slight difference in blood pressure control, that is control under 140/90, defined by office visits, that was a little higher in the smartphone connected group, but that was a secondary outcome. Patients really liked both of these devices, generally speaking, so that was not the issue. It was really more that the smartphone app itself didn't provide a lot of additional benefit. These are subgroups. I won't go through these, but you can see that basically the effect of the study, which is the difference in the blood pressure control across the two arms, is not a lot different in different subgroups. So there's not a lot of interaction here, or particular subgroups that are getting more out of it than others. Okay, this is a little interesting side note here, looking at just the arm of the smartphone connected patients, and just the patients that were successfully connected their device to our research platform. We can see that their measurements at home, that's the light blue here, are lower than the measurements in clinic on average. So that's a kind of a known effect, but you can also see that this self-measured blood pressure gets below the 130 threshold here, and probably indicates that patients are feeling like they're getting under control. And they may not be under control by their office measurements, but they are by their self-measured blood pressure. And that's something we're going to be looking into more. We don't have a randomized comparison there because we just only have these measurements from patients in the smartphone connected on, but it's worth, I think, looking into more. Okay, so bottom line, just having smartphone app doesn't actually help a lot with blood pressure control. There's also an interesting, finding here that office-based measurements are noisy and imperfect and may not be reflecting what's really happening in terms of blood pressure control for individual patients. Quickly, what's next? We have plans here to look at wave 7 of BP track, and that really is going to help us see whether or not blood pressure control rates have bounced back after that big dip that happened in 2020. I suspect that they will, now that I think patient care is really getting back more to normal. But there are really some other interesting things now going on in terms of telehealth and perhaps more self-measured blood pressure that we're going to try to measure as well in BP track. So we're developing a couple of new metrics here that we'll be sending out across our BP track collaborators to see if we can detect these increases in telehealth that we know are occurring. There's some measurement issues there, which is one of the other things that we're trying to sort of get a handle on so that we can really have confidence in whether or not and how much telehealth is happening, in particular for blood pressure control. I think there's an opportunity here to also look at what happened during the pandemic, which really was kind of a natural experiment in how institutions reacted to the pandemic in terms of telehealth and self-measurement, and to see what worked, see which institutions maintained blood pressure control rates or improved them versus which ones really had a substantial drop-off in quality of care. So we're looking into that in particular with OCHIN, I think is interested in working with us on that one. We are also looking into new technology for blood pressure measurement, in particular wearable technology that allows patients to strap on, for example, a watch or stick a patch on a chest and get essentially continuous blood pressure measurements over time for those patients with new technology, a new approach to measurement. It's probably less accurate, but provides a lot more measurement with a lot less effort from patients, and could be really a kind of game changer for blood pressure control and healthcare if we can do it right. And we also have this new clinical decision support application called EngageRx that one of my colleagues is developing that will hopefully help clinicians just make quicker and easier decisions about when to intensify medications and which medications are potentially optimal for care. So we're interested to see if that also helps things as well. Okay, I think I'll end there and take some questions, and just want to end with another thank you to OCHIN for all the nice collaboration over the years.
All right. Well, thank you, Dr. Pletcher, for that fantastic presentation. And thank you to everyone who attended today's session. Be sure to follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on those past Grand Rounds presentations. And stay tuned for next month's OCHIN Grand Rounds, when on November 17th from 12 to 1 p.m. Pacific time, we welcome Dr. Seth Berkowitz of the University of North Carolina as he presents on cash benchmarking for health-related social needs interventions. Invitations to this presentation will be sent 2 weeks prior to the event, but if you're not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN and Dr. Pletcher, to all of you, have a wonderful rest of your day and stay healthy out there.
Thank you.